Very good afternoon to all. Happy to see you all again. Today we are going to learn about the wound management part 2. So last week we learned about wound management part 1, that is pressure ulcer. Today we are going to learn about the cancer wound, that is fungating wound. This session will be taken by Sister Reshma. Reshma is our session head of our home care services. She has around 5 years of experience in palliative care. She has various experience in inpatient department, outpatient department, and home care department. She is an excellent person to deliver this topic today. So, Reshma, welcome and over to you.
Thank you, sister, for nice introduction. Good afternoon to all. Last class we discussed about pressure ulcers, and today we are discussing about fungating wound. Pressure ulcer and fungating wound are the most common wounds that we are seeing in palliative care, and today we are discussing in more detail about the fungating wound. I think all of you are familiar with fungating wounds. And what do you know about fungating wound? What do you mean by an fungating wound? Any idea? What is a fungating wound? We know what is pressure ulcer. Today we are talking about cancer wound or fungating wound.
You can unmute yourself, or you can put it in the chat box as well.
Okay, let's see. Fungating wound, the definition, it is a primary or secondary malignant growth in the skin which has ulcerated and difficult to heal. And the term fungating refers to a malignant process involving both ulceration and proliferative growth. This picture shows a fungating wound. We know most of the fungating wounds are in cauliflower in shape or nodular fungus shape. And next about the pathophysiology. In pathophysiology, there is a development of non-tender skin nodules, and gradually these skin nodules will enlarge. Disruption of capillaries and lymph vessels will occur, and there may be altered coagulation and disorganized circulation. This will lead to tissue hypoxia and necrosis. This is the pathophysiology. There is a development of skin nodule, then enlargement will happen. Disruption of capillaries and lymph vessels will occur, lead to altered coagulation and disorganized circulation, will lead to tissue hypoxia and necrosis. Okay, how many of you know about Marjolin's ulcer? What is Marjolin's ulcer? What do you mean by Marjolin's ulcer? Any idea?
Please respond.
Anybody heard about Marjolin's ulcer? Any idea? Okay, let's see. Marjolin's ulcer, it is a type of malignancy of the skin or a malignant change in a chronic wound. The chronic wound may be a burn scar, pressure ulcer, or a venous leg ulcer. The main difference is here there is a chronic wound and there is a malignant change in that chronic wound. That is Marjolin's ulcer. The chronic wound may be burn scar, pressure ulcer, or venous leg ulcer. The pathophysiology is we have a chronic wound in there. Chronic wound is there and appearance of mass in the wound. and onset of wound pain not previously present. And there is a change in the character, volume, and appearance of the drainage will occur. And if we are doing biopsy for this wound, it will show malignant changes. This is Marjolin's ulcer. Is it clear? Here the patient is already having a chronic wound. Is it clear? Next, let's imagine if we have a fungating wound on the cheek or anywhere, what are the areas we should address? What are the problems we are going to face?
Foul smell, discharge.
The patient may feel there is some physical problems, then psychological problems are there, then social and spiritual. What are the problems coming under physical? Kindly unmute and please tell your answers. What are the physical problems the patient is going to face?
Foul smell.
Yes, foul smell.
Bleeding or discharge from the wound.
Yeah, there is a chance of bleeding from the wound.
Or any discharge from the wound.
Yeah, there may be chewing problem. Then
swallowing.
Yeah, swallowing difficulty may be there. Yeah, there are some physical problems. We know definitely the patient may feel pain because the skin layers are open and the chances of pain is more. What are the two types of pain? What are the types of pain?
Acute and chronic.
Then any other classification? There is a chance of nociceptive and neuropathic pain, and the management of pain is different with our assessment. If it is nociceptive pain, the management is different, and it is neuropathic, the management is other one. And so in physical, the first point is patient may experience pain. Then malodor. Malodor is caused by the odor of anaerobic infection of the fungating wound and the odor of fatty acids produced in the necrotizing cancer tissue. We know there is an infection and there is a anaerobic infection is there. There is a chance of production of malodors. So it is a major physical problems that we are facing in fungating wound. Third one is bleeding. How bleeding will occur? How the bleeding will occur?
The vessels are open.
Yes, the vessels are open. So there is a chance of bleeding. So we should take care of the chances of bleeding by taking care of a patient with fungating wound. Then exudates. What do you mean by exudates?
Discharge.
Yeah, it is a purulent discharge from the wound. Exudates are the fluid, cells or other cellular substances that are slowly discharged from blood vessels, usually from a inflamed tissue. These are the purulent discharges from the wound. So there is a chance of exudates and sometimes patient may feel itching also. Then infestation with maggots. What do you mean by infestation with maggots? As all we know, if we are not covering the wound properly, there is a chance of infestation with maggots. So we will take precautions to prevent the infestation with maggots in a patients with any open wound. Then communication difficulties. In head and neck cancer, we know most of the wounds are located in the cheek or neck region and patient can't able to communicate properly with that large wound dressing and the pain of the wound. So there may be a chance of communication difficulties. Then we are discussing about the psychological problems faced by the patient. We know if there is a wound or any injury to any of our body, there is a alteration of our body image. Like that, for a fungating wound patient, here is also a altered body image is there. Then the sexuality may be affected and patient may feel denied. He will not accept the situation. He will always deny and he has a fear of is it contagious or is there is any chance of hemorrhage. These are the fears mostly faced by these patients. And this will lead to depression and anxiety. Patient may feel shame and guilt. These are the points coming under psychological. Mainly altered body image, sexuality, denial, fear, depression, anxiety, and patient may feel shame and guilt. And next is about the social problems. We know if there is a person with fungating wound, most probably they will not come to the front of the house or sit out like that. They will always in a room. And some of them believes that fungating wounds is contagious and if we visited there, it will spread to us. So it will lead to family isolation. Then they will face social isolation and social stigma and fear of contagion. And this will adversely affect on the family dynamics and will adversely affect the sexual relationship with the partners and will lead to marital disharmony. And about the spiritual, some of them believes that it may occur due to the interference with religious rites. Most of them believes like that. The fungating wound is because of the interference with the religious rites. And some of them believes that it is a punishment from the God. And they may feel fear of impending death. These are the main points coming under the physical, psychological, social, and spiritual problems faced by a patient with fungating wound. And in assessment, as a nurse, what are the points we should assess with a patient with fungating wound? What are the assessments? Assessment points include and we are the nurse, we are attending a fungating wound patient. What are the points we should assess? First of all, we should assess the wound location. Wound location is very important. If in head and neck cancers, most of the wounds are in head and cheek, head and neck area, and there may be a large dressing, and that area and large dressing in that area, and due to this dressing, the patient cannot move to the cannot move or go to anywhere due to this large dressing. So we should assess the wound location. Is it affect the mobility of the patient? That is very important. If the wound is in the chin or neck region, it is very difficult to handle that type of patient. And it is in the cheek, it is very difficult to cover with public view also. So we should assess the wound location. Next is about the wound appearance. What are the points in wound appearance we should assess? If we are seeing a patient with fungating wound, what are the points coming under wound appearance?
Whether it is bleeding or necrotic tissue is there.
Okay, we should assess for necrotic tissue. Yes, size and wound deep, discharge order.
Size, depth,
Yes. Depth, okay. In each visit, in each patient consultation, we should measure the wound size.
And we the should, appearance, how the
yes,
cauliflower-like appearance or yes. How it is, or maggots are present.
Yes, how the wound edges, how was the wound edges, and how was the peri-wound skin. And we should assess the type of wound tissue also. Is there any granulation tissue or there is any slough or necrotic tissue? That's why we should assess the wound tissue. Then we should assess for any presence of exudates. If exudates are present, we should clearly document the color and if there is any presence of odor. These are the points coming under wound appearance, and surrounding tissue we should assess. Then we know there are potential for some complications. If the wound is in this area, neck area, there is a potential chance for obstruction, or there is a chance of hemorrhage from the major blood vessels. So we should instruct the patient about the potential for complications. Hemorrhage is one of the most common complications that we are seeing in head and neck cancers. So at the time of assessment, we should assess for any risk for complications. And principles of management include, we know we cannot able to treat or cure fungating wound completely. We can only manage the symptoms. We can only improve the quality of life of the patient by managing their symptoms. So principles of management, the first point include palliation of symptom. In palliation of symptoms, we already discussed about the symptoms. We should reduce the pain. Then how we are going to reduce the pain? If the patient is having pain, we should give pain analgesics. Yes, pain analgesic medicines for that patient. So in palliation of symptoms, we should reduce the pain. Then controlling odor and infection. Then we know if a fungating wound with malodor is very difficult, that patient to treat, and so we should control the odor and infection. Then managing exudate. Managing exudate is then we know in some wounds there is more exudates are there. In that situation, we can use more dressing pads to that wound dressing. So managing exudates, then minimize bleeding. Most probably the bleeding may occur at the time of wound dressing. So we should take precautions to avoid bleeding while doing wound dressing. Then second holistic management include holistic care. We are approaching the patient as a whole. We are addressing physical, psychological and social and spiritual aspect we are managing. And we should empower the patient and family in wound care. It is very important. We should teach them how to manage these complications and how to manage these symptoms. Then criteria for wound dressing. In criteria for wound dressing, our main goal of care is to maintain or improve the quality of life through symptom control. As I already said, there is no cure. We cannot able to cure it completely. We can only improve the quality of life of the patient through symptom control. Here we are using empathetic care. Just what do you mean by empathetic care? What do you mean by empathetic care?
That place.
Yeah, let's imagine we are in that place. That is empathetic care. Then it is very easy to manage. Then provide a thorough bath before dressing. If the patient is walkable, just encourage them to take a thorough bath before dressing. It will allow deep cleaning of the wound and will minimize bleeding and pain. So provide a thorough bath before dressing is very important. Then ensure the patient had a dose of analgesics before dressing. If the patient is having pain, we should address the pain of the patient. If the patient is having, according to the assessment, we can choose the analgesics. But we should instruct them to take analgesics before dressing. And we are only using normal saline for cleaning fungating wound. We are not using anything else to clean a fungating wound. We are only using normal saline. It is very important. We are not using hydrogen peroxide or povidone iodine for cleaning a fungating wound. And dressing selection is very important. In some wounds, there may be more exudates. So for that dressings, we need more dressing pads. So according to the wound, we should select the wound dressing. Then we already discussed about pain. In minimizing pain, if the patient is, we know the dermis and the skin layers are already open, the patient should experience pain. And if the patient is experiencing deep pain or nociceptive pain, patient may report aching, stabbing or continuous pain. How we are managing is, we will adjust the systemic analgesics. By adjusting systemic analgesics, we are managing patients' deep pain. And some of the patients may experience burning and pricking type of pain. These are superficial pains. And for these type of pains, we are applying local applications like sensocrine and lignocaine. In usually what we are using is, we are using injection bupivacaine 0.5% and injection bupivacaine 0.25% for local application before dressing. Most of our patients are reporting burning and pricking type of pain. That situation, if we have injection bupivacaine 0.5% with us, we will take 3 ml of bupivacaine and mix it with normal saline in a 10 cc syringe, and we can apply it locally. That's why we are managing superficial pains. That's then if it is 0.25, we can take it as twice. If we are taking 0.5 as 3 ml, if it is 0.25, we can take it as 6. Like that, we are minimizing pain. Then another major physical problems these patients are facing is malodor. We know malodor is mainly due to the anaerobic infection, and daily cleaning and dressing is very important, and encourage the patient to take a thorough bath daily before dressing. And we know metronidazole. In bed sores, we already discussed about metronidazole. For foul smelling wounds, we are using metronidazole. Like that, in fungating wound also, we are using the metronidazole. And metronidazole ointments are available in market, but it is expensive. So what we are doing is, we will crush the metronidazole tablets and make it as powder and mix it with white petroleum jelly or liquid paraffin, and that time it will like metronidazole ointment, and we can apply it in the wound. And we know fungating wound structures are very complicated and difficult to clean. In that situations, if we are applying more metronidazole powder, there is a chance of bleeding while cleaning. For that type of wound, we can use injection metronidazole irrigation. After cleaning with normal saline, we can use injection metronidazole irrigation. And if the foul smell is more, we can give injection metronidazole nebulization for 6th hourly for that patient. Or we can start it as 6th hourly injection metronidazole nebulization. And we can also give systemic antibiotics. Then a frequent changing of dressing. If there is more exudates are present, there is a need of frequent changing of dressing. If the patient is having pain, then we can manage it with more additional dressing pads to avoid malodor. Then we are not using hydrogen peroxide or betadine for cleaning a fungating wound. We are only using normal saline. If there is foul smell is there, after normal saline irrigation, we can use injection metronidazole irrigation for cleaning that wound. It will prevent malodor. Then bleeding. Bleeding. How bleeding occur? Most of the time, while doing the old dressing pads, the bleeding is happening. So we should encourage them, and we should practice before removing the old pad. It should be well soaked. Please remove the older dressing pads after only well soaked. It will prevent bleeding. And if there is mild bleeding is there, we can apply local pressure to that area. And if there is bleeding is persisting, we can use sucralfate powder. Like metronidazole tablets, we can take sucralfate tablets and make it as powder, and we can apply to the bleeding area. And if there is more bleeding is there, we can use injection tranexamic acid. Then in most of our patients are in home care settings, and while doing dressing, if we are noticing a bleeding, what we are doing is we will give one stat dose of injection ethamsulate 500 mg to that patient, and we will start tap ethamsulate 500 mg for 5 days for that patient, most probably for TDS for that patient. That's why we are managing bleeding. Then palliative radiotherapy. In palliative radiotherapy, after palliative radiotherapy, the wound size may shrink and it will prevent bleeding for some more time. That's why radiotherapy helps in preventing bleeding. And we know most common complications that we are expecting in a fungating wound is hemorrhage. So we will instruct the family and patient to keep one dark color cloth near to them and inform them there is a chance of bleeding. At that, when we are visiting the patient, we should assess the location and find out there is any chance of hemorrhage, and if there is any chance, we should instruct them to take a dark cloth near to them and inform them about the risk of bleeding. Then role of cancer therapy. Role of cancer therapy in fungating wound. I already said in radiotherapy, what they are doing is after radiotherapy, the wound size may shrink, and for some more time, the symptoms will subside. And in cytotoxic chemotherapy, they will in cytotoxic chemotherapy, what they are doing is they will destroy the cancer cells. And cytotoxic drugs inhibit the cell division. That is the importance of cytotoxic chemotherapy in managing fungating wound. Then in hormone therapy, what is happening is can be used to treat certain kind of cancers by stopping or slowing its growth. While giving hormone therapy, it will stop or slow down the cancer cell growth. That's why it is help. Then surgery. In surgery, surgery is only purely depend on the patient's wound site and the opinion from the surgeon. In surgery, rarely some of them are practicing palliative abrasion along with wound resurfacing, and it will help to the decrease wound secretion, odor, and risk for infection. These all are not helping to cure or completely treat the fungating wound. These are only help us to control the symptoms. Then maggots. What do you mean with maggots? Maggots.
Worm.
Flies sits on the wound, and when they lay eggs, the maggots are formed.
Yes. Okay. We already discussed that pain is a major physical problems that we are facing in fungating wound. And most of the time patient may experience pain, and due to this pain, most of the patient will keep the wound open. And this will, what happened is, some flies will deposit their eggs on or near the wound and maggots will form. This is what happening in maggots. And we know all the patients are experiencing pain. Most of the patients are keeping their wound open while they are experiencing severe pain. That is the main reason for maggots formation. And the prevention is very important. We should instruct the patient to cover the wound. Any type of wound, we should instruct them to cover it properly. Otherwise, there is a chance of maggots formation. And we can instruct them to use mosquito nets. And not only personal hygiene, but environmental hygiene is very important. So we should instruct them to maintain proper personal and environmental hygiene. And how many of you managed wounds with maggots? How many of you managed?
Yes, ma'am. We are working in leprosy. Lot
Ma'am?
of cases. We are working in leprosy.
Okay,
Lot
ma'am.
of cases. Maggot cells.
Okay, from how you are removing the maggots, ma'am? If there is maggots, how you are removing that?
We are using the usual soaking and turpentine dressing.
Turpentine dressing.
Yes.
As ma'am said, we are also using turpentine for removing the maggots. An application of turpentine helps to remove the maggots, and it creates an atmosphere deficit in oxygen, which forces the maggots to come to the surface, and then they can be mechanically removed. When we are applying turpentine, we are not applying directly to the wound. It will cause skin irritation and skin irritation to the patient. So we are only using turpentine soaked pads. What happened is it will create an atmosphere deficit in oxygen, and which forces the maggots to come out. And main thing is, please do not follow on maggots. It may cause injury. When they come out, we can pick it up with the artery forceps. And physical removal is we are doing in turpentine. One major thing is we are not applying turpentine directly to the skin. It will cause skin irritation. And major point is we should wound should be covered with dressing all time and changed daily. It is very important. We should encourage them to cover the wound dressing. If there is pain, we should manage it with analgesics or any topical applications, and we should instruct them to cover the wound properly and encourage them to do daily dressing. Thank you.
Thank you, Reshma, for the wonderful presentation. Anybody have any doubts on this? Please ask. Or if you want to share your experience also, you can.
For the leg wound and all in a hospital, they take it in a bucket, 1-2 liter water, something. Then they add turpentine. They'll ask the patient to dip the leg in that. So after some time, all the maggots will be coming.
Ma'am, can you tell more loudly? Your voice was breaking. Remedy, ma'am?
Usually diabetic patient and all, or some roadside patient, old patient, they have big wounds with the maggots. So when they come to the casualty, we give 1 bucket full of water. We add little turpentine. When ask the patient to dip the leg in the water, so all the maggots will be coming out. After the maggots are out, then we do the dressing.
Okay. So you will be soaking the legs with the water with turpentine oil, right?
Yes, madam.
Okay, that
We
is
add
the
little
again
turpentine in the
diluted.
water.
So
Yes,
okay,
yes.
that is not a concentrated turpentine oil. You can dilute it and then so that will not irritate the skin. If you apply directly the concentrated turpentine oil to this wound, it will be irritation and it will be irritated to the skin, and that leads to pain also. So better you can soak with a gauze piece and keep close to the wound so that the maggots will not get any oxygen, so that the maggots will come out. That time you can remove physically. You can use artery forceps to remove the maggots. And as Reshma said earlier, don't follow maggots. That is also very, very important. If you follow, there are a lot of pocket formation inside the wound. So they go in when you go with your artery forces, they usually go inside and keep safe there because lot of pocket formation there. No, so even if you follow maggots, what happen? Your artery forces will rupture the blood vessels that leads to bleeding. So better you don't follow maggots. When they come out, you can take it out. Otherwise, you can leave it.
And
Thank you.
for the surrounding, sometime no, madam, the ants flies will be coming. So what we do, we take a cotton ball, dip it in the turpentine, where the patient's bed is there. Just rub it all around the bed so that ants will not come.
Okay.
Ma'am, we are using 100 ml liquid paraffin with 5 ml turpentine mixing and using the dressing also, ma'am.
Okay. So any other points you want to discuss? So regarding the malodor, Reshma has mentioned many things about the management of malodor, especially the metronidazole application. So metronidazole is one of the good drug for controlling anaerobic bacterial infections. You can use metronidazole for controlling bad smell. And the next thing is charcoal. So charcoal is another agent for absorbing bad smell. So that is also you can suggest, especially these kind of wounds are having lot of malodor. This will be affecting the patient as well as the family. So, and the another option Reshma was sharing is a nebulization, metronidazole nebulization and irrigation. So, how will you give nebulization? Can anyone say? She has mentioned about the metronidazole nebulization, right? For
Yes,
controlling bad. Yeah.
yes.
Yeah. How will you give? Any idea?
IV, ma'am.
Sorry.
IV.
IV.
Intravenous.
No, we are talking about nebulization, metronidazole nebulization. So Reshma was saying like for controlling bad smell, malodor, you can either irrigate with metronidazole or you can give metronidazole nebulization. So my question is, how will you give metronidazole nebulization? I hope my question is clear to everyone.
Uh, Maybe how we are giving nebulization for children at home. That way, in the water, maybe we can add little injection metronidazole, and when you switch on, the smoke will be coming. That smoke can be shown to the wound directly. So that will be
That is very important. That fumes you can take. So you can take metronidazole injection instead of asthalin or whatever it is. We usually use asthalin and the Budicort, something like that for nebulization. So instead of that, you can use metronidazole. You can take metronidazole. So after that, the fumes. So the fumes you have to give to the wound directly. Okay, so that is that is what that Deshma was saying. The nebulization. When you give nebulization to the wound, you can give the metronidazole yeah, that nebulization to the wound directly. That fumes will help to control the bad smell. Any other questions? And also that Reshma was saying like pain. So pain is one of the most the irritable problem, because the patients might have developed neuropathic pain and nociceptive pain. So the proper assessment is mandatory, because if the patient is having neuropathic pain, your systemic analgesics may not help. So that time you have to give some topical anesthetic agent. You can before dressings you have to give some anesthetic agent like local anesthetic agent to the wound and make the wound pain free, because if you use a local anesthetic agent, within 10 minutes the patients will get a local anesthetic effect, so that you can give proper dressings without pain. So make sure that the patient is having pain or not. So you have to keep it in mind always before dressings.
जो देना है उस कितने में कितना डाइल्यूट करना है?
Sorry. You can we usually take bupivacaine, that is sensorcaine. Take 3 ml sensorcaine and add 9 ml of normal saline, and then you can apply on the wound. So within 10 minutes, the patients will get local anesthetic effect. Reshma, am I clear?
Usually, if the bupivacaine is 0.5 is available, we will take 3 ml of 0.5 and plus 7 ml and normal saline. Ma'am?
Okay. Okay. Thank you. Okay. I think we can move on to the case presentation. Sunita ma'am will be presenting the patient story today.
There is
So
there is one more question in the chat box. After giving nebulization, can close dress with plain dressing pad? If there is foul smell, we can pack that wound with metronidazole dressing pad. We can apply metronidazole on the pad and we can apply on the wound. It will help to reduce the odor.
And also one more thing you want to all keep it in mind is this wound have a lot of necrotic tissues. This is the slough debridement is not possible, not indicated, because if you do the slough debridement, what happened? Again the slough, the black necrotic tissues will be coming, and also when you try to remove the slough, it might be damage the blood vessels also. So better you won't do any slough debridement in fungating ulcer, but if you can do the slough debridement in the bed sore. So another important point, the major difference between the pressure ulcer and the fungating wound is pressure ulcer is most of the time preventable and curable. So the fungating ulcer, the cancer wound is the not preventable and not curable. So these are the major difference between the pressure ulcer and the fungating wound. Any more questions, Reshma?
No, ma'am.
No. So I think we can move on to the case presentation. In the meantime, if you have any questions, please put it in the chat box. So we will discuss later. Thank you.
Ma'am.
Good evening, ma'am.
Good evening. Good evening.
Today I am presenting case of theatum. Presenting complaint of oral cavity, pain 4/10 as per NRS scale, dysphagia, pain in oral cavity right more than left, burning pain in oral cavity, increase of feeding. 46-year-old male patient, diagnosed case of inoperable sear tongue, biopsy 13 January 2023. MDSCC invented radical radiotherapy 70G, 35 fraction from 2 March 2023 to 20 April 2023 in Indrayani Hospital, Anandi, Pune, under Dr. Bhushan Jade. Also received 6 cycle of concurrent weekly cisplatin chemotherapy from 2 November 2023 to 15 December 2023. June PET scan shows good response to treatment. Now presented with ulcerative lesion or right side oral cavity and tongue residual disease, right hard palate edema, admitted for symptom management and wound management. Physical examination, general appearance, body build, thin posture, hygiene, grooming, maintaining, body and breath, odor, no, attitude, moderate, height, weight 145 centimeter, height 145 centimeter, weight 48 kg, vital sign, temperature 97.0 Fahrenheit, pulse 93, respiration 20 per minute, blood pressure 120 by 80, or visual activity, clear vision, able to see normal distance, visual field, no any conjunctiva, pale, pupil normal, reacting to lights. Investigation में CBC, RFT, LFT, hemoglobin 6.8, RBC 3.32, WBC 19.7, ECV 24.6, neutrophil 84, lymphocyte 5, and bilirubin 0.37, protein 4.4, creat 0.97, and electrolyte sodium 123, potassium 6, fluoride 89. Medication, patient having pain, morphine sulfate 10 mg oral, QID, neuropathic pain, neuropathic pain, side effect, feeling sleepy, nausea, vomiting, diarrhea, dry mouth, headache, tired and dizzy. Nurse responsibility may observe the symptom and take correct action. Next dose, next medication, gabapentin 100 mg oral TDS, neuropathic analgesic. Side effect may feeling sleepy, nausea, vomiting, diarrhea, dry mouth, headache, tired or dizziness. Nurse's responsibility, observe the symptom and take correct action. Next dose, pantoprazole 40 mg oral OD, protein pump inhibitor. उसका साइड इफेक्ट headache, diarrhea, nausea, stomatitis, stomachache, watery stool, and dizziness. Nurses' responsibility to observe the symptom and take correct action. Significant investigation, communal sear tongue diagnosed on 13/1/2023, biopsy from tongue moderately differentiated squamous cell carcinoma. Psychological aspect, no history of psychological aspect. Medication done. I already discussed medication. Main concern, wound management, dressing 2 times a day, use aseptic technique, health education about personal hygiene, high protein diet. Summary, patient was very friendly, cooperative and humble. While giving him nursing care, I was emotionally attached with him and his family. So I was aware that he is not going to survive. I tried to give best care and tried to reduce his pain at the ending stage of his life and tried to give him comfort. His fever controlled by giving proper medication and nursing care. Patient able to perform minimal ADL and able to move around and do all activities independently. Discussion point, health education given to patient, how to manage wound at home, change habit of smoking and tobacco chewing, and diet planning. Thank you, ma'am.
Thank you, Sunita, for the presentation. Anybody need any more clarification regarding this patient story? Please ask. Anybody?
Social aspect and psychological aspect can be included in a better way because the patient was diagnosed in 2023. Now, after taking all the chemotherapy, radiotherapy, in spite of taking the treatment, patient was had the recurrence. So the psychological aspect maybe a little more we can specify.
Yes, that is true. What happened, Sunita sister? Is there any psychosocial issues?
No, ma'am.
No. Did you assess?
Yes.
Okay. What is the family history?
इस family history में one daughter and one son, और सन इन 12th में था, और उसकी डॉटर थी वो 10th 12th में थी.
Okay.
हाँ, a
What
small
about
family.
okay? What about his wife? His wife is working or not?
Not. This is his wife is housewife.
Okay.
And हाँ, हिस्ट्री में था उसको स्मोकिंग और टोबैको चिविंग.
Okay. What about the income, financial things and also how are they overcome? Because the patient is not able to, he is the breadwinner of the patient, the family. Now he is not able to go for work. He is in a uh, he is not able to do anything, no?
Yes.
So yeah, there are I think there will be a lot of psychosocial issues there because definitely he will be worrying about his children. They are studying. So,
Yeah.
and after that, how will they move forward? These all things definitely inside his mind always. So if you assess well, definitely he will explore his emotions. I think others also feel the same thing. What about others feel? Others, please respond. What do you think? Yes, Ramani ma'am said 10th and 12th standard. Yeah. So again, yeah, children are studying in 10th and 12th standard. So again, so this will be affecting the patient emotionally, socially, and spiritually.
Because a patient may not be opened up, so he may be having all the stress and thoughts in his mind. So it is definitely a burden to him. Only he must be thinking about the family, children, wife, his future, everything.
Yeah, yeah. And also he has some bad habits also. So he always think like, okay, due to this bad habit, I uh, have developed these kind of illness, these kind of spiritual the thinking also there. So better you have to, if possible, please explore his emotions. Kindly go back, Sangeet, go back to the medication slide.
Okay, ma'am.
Yeah, thank you. Uh, so I would like to hear from the participant side. Is there any modification needed for this medication chart? We learned many things. Uh, Pain class is over. introduction pain, management of pain, all classes are over. Now you are able to answer question. So is there any modification needed for this medication chart? Anybody?
The patient is having diarrhea because of all the medicine, but for diarrhea, nothing is given.
Diarrhea. Sunita sister, what is the history? Is there any particular history of diarrhea?
No, ma'am.
No. Since how long the patient is having diarrhea? I didn't see. So this patient is having diarrhea or not? Sunita sister, my question is clear. Am I clear? Somebody's mentioned about diarrhea. I didn't see that. My question is that patient is having diarrhea or not? Sangeet, go back to the main concern that things. Previous. Previous. No diarrhea. No diarrhea. Okay.
No, madam. And the medicine and the side effects, they have underlined diarrhea in all three things. The GABA, what is that, morphine, they have underlined with a red. So I thought it may be the patient is having diarrhea. That is why the diarrhea is highlighted in pantoprazole and morphine. So that was my guessing. The history they have not mentioned. The drugs and the side effects, they have highlighted diarrhea. So I thought the patient may be having diarrhea.
Am I audible?
Yes, ma'am.
Sangeet?
Yes, ma'am.
Yeah. Okay. So yeah. So I was wondering that medications chart. No, the we all learned that tabomorphine cause constipation. Okay, the most common side effect of morphine is constipation, but this patient is not having any stimulant laxatives. So these patients definitely develop constipation. This patient is not having stimulant laxatives. You should add stimulant laxatives. So that is one of the important points you have to notice here. So because the patient is having morphine, gabapentin for neuropathic pain, pantoprazole for maybe any history of gastritis there, you can add pantoprazole. But at the same time, you have to keep it in mind. The morphine will cause constipation. So if the patient is having constipation, that leads to many problems because so that is loss of appetite. In some day, there are a lot of problems. So you have to give some stimulant laxatives and proper assessment of constipation is also necessary. Anybody wants to add anything?
Ma'am, I want to add that if we are giving morphine,
metoclopramide.
You can add metoclopramide, but the thing is, only 3 days. If you start with metoclopramide, the initially that first for a opioid naive patient, then you can think about and the metoclopramide. But after 3 days, it is self-limiting only. The patients get used because no need of after 3 days. After that, no need of metoclopramide. But in the initial period, you can give metoclopramide, but after that you can stop. But you have to continue the stimulant laxatives.
Dalcolax.
Yes, Dalcolax is
Yes.
the stimulant laxatives.
Ma'am, dysphagia is there, no?
Yes, dysphagia. So what are the causes of dysphagia? What are the causes of dysphagia in palliative care? There are many causes of dysphagia, but in palliative care, what are the most common causes? So one of the
Extension
most
disease.
yes. It could be leads to the disease progression, but in palliative care, one of the most common causes oral thrush, oral candidiasis. If the patient is having oral candidiasis, the patients might have developed dysphagia. Sometimes it could be extend to the esophagus too. So that time, definitely the patients will tell you like, I'm not able to swallow properly. So if the patient is complaining of this kind of that dysphagia, you have to check the oral cavity whether the patient is having oral candidiasis or not. If the patient is having oral candidiasis, give some the antifungal management like fluconazole or candid mouth paint or something like that, so that candidiasis will we can control the candidiasis with the antifungal management. Any other thing you want to discuss? And the discussion points. Yeah. How to manage wound at home. That is one of the discussion points Sister Sunita has mentioned. Please share your thoughts. What all things you will teach to the patient family and patient about wound care?
Family counseling.
Okay, very good. You have to counsel the patient family because nobody is willing to touch these kind of foods because of misconception of the spreading of disease. So you have to give a counseling if needed. Then
Explain the wound condition.
okay. Then
Health education dressing.
okay. How will you sterilize the dressing pad at home?
Pressure cooker.
Boiling.
Can anyone explain, please?
Pressure cooker, small amount of water, then another one vessel, closed in other vessels, put in the gas, cotton pads, close the pressure cooker. One
Okay.
or two whistles.
Yeah. So after that, you have to remove the lid. You can use idli vessel or pressure cooker. You can steam it and then you can open the lid, and that dressing pad they can use for dressing. So before touching that dressing, they should that wash their hands with soap and water. That is one of the important points. They should maintain a good personal hygiene. They before and after dressing, they should wash their hands with soap and water. And then you have to teach the homemade saline preparation also. How will you teach homemade saline preparation?
Take 1 liter of
500
water and
ml,
of salt. Boil it thoroughly.
1
Add little salt.
Yeah, so you can take 500 ml of water
Water
and add
and 1 teaspoon of
yeah,
salt.
1
1 teaspoon of
teaspoon of
salt.
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 Yes, 1 teaspoon of salt and boil it,
Boil
cool
it,
it.
cold it, and
Yeah,
then apply. Then
yeah,
use.
then cool it, and then that water you can use, that
Use
homemade
it.
saline you can use for cleaning, because
Cleaning.
these kind of wounds are not sterile. This is the clean
Clean
wounds.
it up. Clean wood.
We need a clean saline, homemade saline for wound cleaning. So you can
Yes, ma'am.
use you can use homemade saline, and you can teach the patient family about how to make dressing materials at home. Sunita sister, any other questions you would like to ask?
then proper disposable also, ma'am, dressing materials.
Sorry?
Proper disposable also, ma'am, dressing materials.
Disposal. Okay,
Yes.
in home care. So what shall we do? What shall we do?
You are preparing the paper bag.
Yeah. So we don't have an incinerator into the home. What we suggest is we usually ask them to burn that dressing materials, and that is the only way that this is the cotton materials, no, so easily that will burn. So yeah, that's why we suggest here. Any other suggestions? In home, but in hospital there are many ways, but in home we can teach these kind of things. So and also burial is also another way. Burial is also, if they have land, they can do that. And the change of habit of smoking and tobacco chewing. So now, so what about the health status of the patient now, Sunita sister? Still the patient is chewing tobacco and smoking? Sister Sunita, are you there? Sangeet, yeah, Sister Sunita is there or not?
She's not responding as well. She's been muted.
Okay, fine. So I think usually when they come to when they develop these kind of illness, they usually stop smoking and tobacco chewing. Usually, the I have seen these kind of things, but I would like to know from her, because still the patient is smoking or tobacco chewing. I don't know exactly. So, and the diet planning is also especially.
Ma'am, your voice is breaking.
Hello, ma'am.
This patient is sorry.
Hello, ma'am.
Yes, yes.
I'm audible.
Yeah. Yes,
हाँ.
yes, you are audible.
हाँ. पेशेंट
Yeah.
स्मोकिंग कर रहा था,
Okay.
Ah.
What
For
about tobacco chewing?
no ma'am, tobacco no, लेकिन smoking
Okay, nothing.
at the
So, yeah. Okay, so that's good.
और डाइट प्लानिंग में हाई फाइबर डाइट, हाई प्रोटीन डाइट, और उसका हीमोग्लोबिन लो था इसलिए आयरन सजेस्ट किया.
Is he able to? You have mentioned about dysphagia. So how did he swallow these kind of foods? Is he able to swallow?
Yeah, liquid diet.
Okay. So please do one thing. You please check his oral cavity. You can check whether the oral thrush is having or not. Oral candidiasis. If the patient is having oral candidiasis, give some antifungal.
Yes, ma'am. Stomatitis.
Okay. Stomatitis were there, right?
Yes, ma'am.
Okay. How did you manage?
Mucopain gel. Apply mucopain gel.
Okay. What about now? What about now? So now the oral cavity is clear or not?
Yes, ma'am. Clear. Or mouth care.
Okay.
Before.
Now there is no dysphagia, right?
Dysphagia present, ma'am.
Okay. So then what you can do is please check the oral cavity for oral candidiasis. So oral candidiasis there, it could be extended to the esophagus too sometimes. Please check for that. If the patient is having that, you have to give some antifungal treatment. So and also provide a good oral hygiene. Did he know the prognosis? What about prognosis? Prognosis. Did he know the diagnosis and prognosis?
Yes, ma'am.
Yes. Okay. So that all. So I think if he knows the prognosis, then we can give symptomatic management. But as we discussed earlier, please talk to him individually and explore his emotions because lot of worry in we are assuming that there are lot of worrying inside his mind because of his family, childrens and all. So because lot of problems will be there. So if possible, please do a proper assessment, especially the psychosocial issues.
Yes, ma'am.
Okay. Anybody wants to add anything? Anybody? So from the beginning onwards, we were discussing about the total care, physical, emotional, social, and spiritual, because this is a non-healing ulcer. So this patient need a that proper care because the physical problems will be there. Try to control the physical problems. At the same time, you have to give a proper attention to the psychosocial, spiritual aspects also. So if you give a proper attention to the other aspects, definitely we can able to improve the quality of life of the patient and their family. So because if he have any wishes or anything he wants to meet, please do arrange for that. Please talk to him and understand his emotions and wishes. I think we can wind up. Anybody have any more questions or any suggestions? No. So we have learned today. We have learned many things, especially fungating wound. Nurses are usually take care of the wounds. So for that we need to understand well about wound care, especially fungating wound. Pressure sore, we all know that, but fungating come to the getting ulcer, it will be difficult. So there are many problems: pain, exudate, bleeding, and malodor. So these all will be affecting the patient and the family too. So what you have to do is, if possible, do the individual assessment in front of the caregivers. They will not tell the truth. They always hide the truth. So if possible, do the individual assessment. Then you will get a good idea about the patient problems, and sometimes the family members will not allow the patient to enter into the kitchen or the dining area or anywhere. They always ask the patient to uh, inside the room, keep the patients inside the room only. So that will be affecting the patient emotionally, socially, and spiritually. Because of my disease, they will not be allowing me to enter into the kitchen or dining area. So in front of others, that in front of the caregivers, you will ask, is there any problem? They will not try that tell the truth. So we usually what you do is, you can do the individual assessment so that you can get a good idea about the patient. And if there is a misconception there, talk to the patient family and understand and their that misconception, and you can try to convince them. So this will not spread by direct contact or something like that. So you have to educate the family members for better care. So otherwise the patient will not get any proper care. And also Reshma was telling about the maggots management. So the maggots comes from flies, house flies. So usually the house flies are attracted with the infected wounds. When they touch the wounds, they may lay eggs. So within 8 to 12 hours, they come out with maggots. So this is very, the proper covering of wound is very, very important. The patient and family members doesn't know how does maggots come. So that is one of the important message you have to tell the patient and the family. How does maggots come? They always, if you tell these things to the family, they always try to cover the wounds with dressing. So that is one of the important things you have to keep it in mind. I think we can wind up the session. Thank you, Reshma, for the wonderful presentation. Thank you, Sister Sunita, for the wonderful patient story. Thank you all for your participation. Thank you.
Thank you, ma'am. Thank you. Thank you. I hope Sister Reshma has taught us very well today with very good presentations. Thank you, Shiva ma'am, for the wonderful facilitation. And thank you, Sunita sister, for bringing up a wonderful case story for discussing and in this session. Thank you all for joining. Well, let's see you in the next session. Bye.